And we'll let Dr. Baloch take it over from here, please.
Okay, so again, thank you for inviting me. And this has been an really amazing conference, and it's been a pleasure to really show you, or at least share what I can share on this. So I'm going to start with something, and I really avoid bringing rare cases because we see them not that very often. But I think it's also important to know things that can happen which do not follow the norm, because that is what really throws the curveballs to us. So I think it's important to know, and I'm kind of a little buff of embryology, how things happen. So I think it's very important to know. So I'm going to present you with some cases that I'm going to do actually just two big cases, and that I think should cover everything. So this is actually a case that got me very interested and was personally a head scratcher for me. This was a 46-year-old male with a 5.5 centimeter solid and hypoechoic. That means it's definitely a cellular tumor or a lesion, was in the left thyroid lobe. So basically had replaced the entire thyroid lobe. There's no family history of thyroid cancer. It's very important to get the family history. Even if it's benign diseases, we have now known that even if there's a family history of benign thyroid disease, the chances of cancer go up. So, and family history also applies to papillary thyroid carcinoma, plus other cancers, which we also know, like medullary thyroid carcinoma. So I think history of benign thyroid disease in the family, plus the cancer, is very important. And there was no history of head and neck radiation, because we know up to 10 years of age, if somebody's exposed to head and neck radiation, they can have actually 30+% higher risk of developing papillary thyroid carcinomas, which is associated with radiation. So this was the sample that I got. And the sample was actually collected at other hospital. There was a diagnosis issued on it. And as you can see on this power, it's a very cellular specimen. It does have a lot of single cells in the background, plus a very cohesive grouping. And this is actually a thin prep specimen. So those of you who do thin prep, you do notice there is a little bit of even a colloid in the background. So it has that really mishmash of a lot of cells. And then when you look at it on high power, what you notice there's definitely follicular structures with thick colloid. Then again, these kind of nondescript structures. And if you really look at those cells, there is chromatin clearing and thickened nuclear membranes on these. And then you also see these cells in the background, which are little plasmacytoid, little oval in shape with kind of even distributed chromatin. So this could be also coming from the same. So we are seeing follicular structures per single cells. Okay, this definitely looks like a neoplasm, and there's some chromatin clearing. Could it be suspicious for papillary thyroid carcinoma? But you have to look at everything on these, and definitely beautiful thick colloid with this crackling sign, which is typical for a thick colloid. And then these nuclei, even on this side, you can see on the upper left of this column, really beautiful small micronucleoli, elongated cells, thickened nuclear membrane. So this is becoming more suspicious for papillary carcinoma. The interesting thing was these cell groups, and I could not put these together because to me, either this is a papillary carcinoma which is going bad, which is the most common scenario that happens in these tumors. That is becoming poorly differentiated carcinoma. So it's basically one cell type. Well, you have a differentiated component on the left, and then you have more undifferentiated component on the right. Now I have this cell here, there's just nucleus, there's no cytoplasm, and our teaching in cytology is that you make only diagnosis on the cells when they are intact. That means you see the nucleus, you see the cytoplasm. But then we know there are some tumors in the body which really do not have a lot of cytoplasm, or their cytoplasm is so delicate that during the cytologic processing, that cytoplasm gets feathered away. So you basically left with a nucleus. So this was actually that. So this is how I signed this case out. I said this is really a distinct population of round to oval cells, which are forming follicles, but there are also these loosely cohesive scattered cells, with eccentric placed nucleoli, somewhat plasmacytoid, and the chromatin really does not. So I basically laid it out. I definitely said this is neoplasm, and it has follicular plus this undifferentiated kind of growth pattern. The patient had paid for the molecular analysis, and the molecular analysis was done, and it came back as positive for medullary thyroid carcinoma because they saw the RET oncogene arrangement in the tumor. Plus, at this point, the clinician went back and did a serum calcitonin level, and they said this is definitely was high, so this is all comes together. This is medullary thyroid carcinoma. But for me, it does not solve something, because then where is this population of follicular cells is coming through, which have these really colloid in there, and it's not amyloid. We are always told that amyloid can mimic colloid, and medullary carcinoma is the big mimicker or a melanoma of the thyroid gland because it can mimic other tumors. But I was actually not settled with this because to me, there was something that was not going through. But I did say, even after that molecular analysis came back, the surgeon wanted me to issue an addendum and call this outright medullary thyroid carcinoma. And thank God, when you become a senior pathologist, you have a little bit of kind of weight in an institution. And I said, look, I am not going to call it outright medullary carcinoma because I just think there is some other neoplastic processes happening where there is these follicle formations. And if it's coming from the same tumor, which was the only one nodule, I think there is something else going on, and it's not your clear-cut medullary thyroid carcinoma case. So the patient underwent total thyroidectomy and central neck dissection. For medullary thyroid carcinomas, the first line where they metastasize is to the central neck, the level 6. And this is always taken out with these thyroidectomy specimens when you give a diagnosis of medullary thyroid carcinoma. So this is actually, I was on SearchPath and I got this case. And as you can see, this tumor definitely has follicle formations on this low power. And again, in the background, as you see, there's a lot of these cells which have kind of clear look to it. So there's little heterogeneous grouping to it. It is encapsulated and not an infiltrative tumor. Now, when you go on high power, you definitely see these beautiful follicles. And in the background, you have these cells which have this clearoid pattern. And when you're looking at thyroid dissections, whenever you have cells which have clear cytoplasm, there's a big differential for that. They may be just reactive follicular cells. But if they are sitting very close to the thyroid follicles, you also think of C cells, because this is how the C cells look like in the thyroid. If you can see them on routine H&E sections, normally you should not, only in children and older adults or who have chronic lymphocytic thyroiditis. But this tumor has definitely intermixed follicles and those clearoid cells. And again, this is on the high power to show you how those nuclei are looking like papillary cancer nuclei along the follicles. And then you have these clearoid cells. Some of them are plasmacytoid, multinucleated, more of a salt and pepper appearance. So this tumor has dual differentiation. This is calcitonin, which does not stain the follicles and only shows you those cells which are in the background. And this is thyroglobulin, which is staining the follicular component and the follicles. This is thyroglobulin and TTF1 together. And as you can see here, TTF1 also stains, this is thyroglobulin, and TTF1 is staining the follicular cells, plus TTF1 will stain up to 50% of medullary carcinoma cells. But Paxid usually does not stain C cells. So this is a case of a mixed medullary and follicular variant of papillary thyroid carcinoma. So these tumors do arise in the thyroid gland. They do have dual differentiations, and they can metastasize as a dual component, or sometimes your metastasis is only one component. Definitely in this one, the more aggressive tumor will be the C cell tumor, which will be actually the medullary carcinoma. This patient also had C cell hyperplasia in the background, and this was actually a late bloomer, MEN1, or familial thyroid carcinoma that was diagnosed in this patient. And this patient actually had a RET mutation, which was one of the rarest mutation in this case. So I just want to kind of bring in the discussion about these tumors, which really do not follow the normal, or I shouldn't say use the word normal, but not something usual that we see in these tumors. And if we look back in the literature, it's very amazing about pathologists when we talk about something or we publish something, we always think it's very novel. But I always go back in the literature and see when it was actually described. And actually, you can see this is actually an article that was published in late 70s by Dr. Zubair. In the back, you can see the pictures are still black and white. And this was an AJCP article, which he published. And this where he described these mixed tumors. And now, if we really think about these tumors, we know that the C cells are the parafollicular cells. What have we been taught so far? That they come from their neural crest origin cells. They are more common in the upper and the middle portion and the lateral portion of the thyroid. If you are thinking of medullary carcinoma in the thyroid isthmus or the lower lobes, even diagnosing on FNA, think twice because there are no C cells in those areas. So medullary carcinomas do not happen in those locations unless the patient has MEN, or multiple endocrine neoplasia syndromes, or familial thyroid carcinoma. So this is what we have been taught so far, that they are neural crest-derived cells. And this way, the whole antibodies were developed, and there's like a really big history behind them, and which I have kind of listed on this. But the interesting thing is that the new data suggests that the parafollicular C cells are also endodermal in origin. And actually, a lot of people have biologists have challenged this. This is based on animal studies, which kind of really throws this out, creates a lot of confusion that the C cells may not be of neural crest, and which kind of explains to me that because of this, they are not of purely neural crest origin. This one cell can split and can give rise to these tumors with dual differentiations, which I think is amazingly fascinating. And that's why I love endocrine pathology. So this stem cell theory is the one that I really pay attention to, because to me, this really proves, or there are two monoclonal populations, that means the medullary carcinoma arising and the follicular variant or follicular, and they come together, which is the dual differentiation. But I believe that now there's one thing I also want to point out, that it's very common that when you have a papillary carcinoma or even a follicular adenoma, if you do calcitonin and stain, you're going to see C cell hyperplasia around those tumors. And I had seen a couple of FNAs, few of the cells coming on even on the FNA. So this is very common phenomena in the thyroid, because the C cells also can react to TSH, which is really stimulates follicular cells, or even inflammatory conditions like chronic lymphocytic thyroiditis can cause C cell hyperplasia. So one has to kind of put this in our heads, so what is happening, because this is a very complex process. These are again my pictures that if you're in Philadelphia, Philadelphia is very, very famous for its mural arts, which are these big paintings that are done on the walls in the streets. And so if you're there, there's a whole tour that can be done in Philadelphia. So I was again on service, and I had this another case of a mixed medullary and papillary thyroid carcinoma. What I want to show you at the bottom is that this tumor actually even metastasized as dual components. And here is the Paxate, which is staining the follicular component, and here is the calcitonin stain, which is staining the. So these tumors can have dual components even in lymph node metastasis. So I think these are fascinating tumors. And these tumors actually even hold a separate place in the WHO classifications. This is whenever I go to the museums and the stuff, I always take pictures and always looking in the magazines for pictures of these. And this is actually a Madonna and child picture, which is actually in Madrid. And what I want to point out, you can see, because they use live models, you can see even goiter on the Madonna's neck. So, you know, so thyroid nodules have been there with us for a long period of time. I think in US, making a diagnosis of carcinoma is not enough, and especially the cases that we call indeterminate, where you have to use everything that we have available of ammunition, which is a very expensive test. But I think cytology does very well, and it really correlates with what we see on radiology as well as on histology. So I think the cytology is the big armor we have on our head to really tackle this disease, which is pretty common because even in US, which has so much iodine in their food, up to 7% of US population can have, you will see palpable thyroid nodules, and up to 60% have thyroid nodules on ultrasound. So this is a very common disease that comes through your cytology bench. These are my mentors that I have either directly, dealt with. They have taught me, including Dr. Rosai and Dr. Lavolsi and Dr. Asa, and the others are the ones who have really taught me by their articles and monographs, and I really am thankful to all of them. So what I have learned in endocrine pathology. So I'm going to go to the next case, which will be my last case, and then I will ask any, if you have time to ask any questions. And this is where I'm going to switch a little bit of gears. So this is actually a case that came to one of my faculty members, Dr. Roseanne Wu, who's an amazing pulmonary pathologist. And whenever I have a difficult pulmonary case, I always take it to her to get her second opinion, because I think lung cytology, as was talked by Dr. Siddiqui, and the effusion cytology by Ashish, you can, these are very complicated cases. And because the follow-up on this, it's the lung cancer kills. So I think it's very important to really, and we, as was pointed out by Dr. Shahid Pervez, that, the cytopathologists we do journal practice. So I think it's important so this case actually taught me a lot. So this was actually her case, and she basically showed me a slide, and we were both holding our hands. This is a BAL, so this was a bronchoalveolar lavage specimen that came through, and there was only one slide, which was the thin prep. So as you can see, there are very atypical cells here. And I'm going to go back to the history a little later once I want to show you these cases. As you can see, large fragments with very abnormal looking cells in those fragments, and even some single cells in the background. This is another group. There's a little bit of inflammation, but these cells have some vacuolations in them, and this looks really large cells. So when you have large cells, definitely they can be malignancy, but you have to think of other things. But the history that was provided in this case was very convincing that there is a lung mass, and it's spiculated, and it definitely looks like cancer. And this is another group, and you can see really, really abnormal pleomorphic cells. And this is where I really sometimes throw my hands in the air, even after doing cytology for 20 plus years, because to me, these are the cases that really kind of tell you to hold back, go to your roots, to the basics, and apply all these concepts, because sometimes the experience does not mean everything. So you really have to think really clearly about these cases. So this case she was convinced that this is a carcinoma. Now, so the diagnosis, naturally, the possibilities are, is this a benign process? Definitely does not look benign. Is it atypical, suspicious, or malignant? I'm going to kind of have you think about it, and I'm going to kind of guide you through the case. So this was the history, that there's this 45-year-old genetic female with a 1.1 centimeter right, let me use my pointer. So this is the nodule, which is kind of spiculated, which goes with this being a carcinoma. She had a history of breast carcinoma, which was metastatic to the axillary lymph nodes. And this nodule was really suspicious for a primary bronchogenic carcinoma. She never smoked tobacco, but she has an occasional using marijuana, and her husband and nobody else in the house smoked. So she was not even exposed to in the house for the secondhand smoke. So very, very, limited history of smoking. And the radiology is very suspicious. So this was diagnosed as polydifferentiated malignant neoplasm. The cell block was very limited. She did try immunostains, but there was not many cells to be stained. So basically it was unsatisfactory. She still went in and called this and said, this could represent a metastasis from patient's breast, because that was a poorly differentiated carcinoma, but could also be a lung primary. So they did a resection. And this is how the resection looked like. The resection had this really kind of a solid pneumonia type pattern, almost like an obstructive pneumonia, or what we used to call as bronchiolitis obliterans, because you can see a lot of like a young fibroblast growth. Plus, you see the same cells that we saw, those atypical cells on cytology. So you can at least correlate and say those cells are there, but this was more of a diffuse process. Again, this kind of like a plugs of this, like a young collagen in the background, and some of these cells kind of hobnailing. So definitely sometimes these patterns can be seen in carcinoma, but this pattern of these macrophage plugs within the alveolar spaces and this really prominent nucleoli and this kind of hobnailing of the pneumocytes, you have to think twice before you call it carcinoma. I do have a disclaimer. I have signed out a couple of the cases of pulmonary pathology, but then I finally said, I can endocrine and head and neck is enough for me, so I cannot do all of it. So, but this pattern to me is also looks more on the pneumonia pattern. We did do a stain for TTF1, and all these stains, so these are definitely pneumocytes or bronchogenic cells, and you can see again how horrible these cells look like. So, at this point, we got more history from the clinician because the breast was not reviewed at hospital. We didn't know what was the treatment was because it was a long time ago. So she did receive massive doses of radiation therapy for this tumor. And this is an example of the radiation-induced nuclear atypia and pneumonitis. So this is how the case was still signed out. It was still called atypical, but was favored that these are highly reactive changes secondary to radiation trauma. The follow-up on this patient is that nodule has resolved on the radiology. There was surrounding, and the patient, they looked back again on the CT and said, yeah, there is some pattern in the background which couldn't be seen in radiation pneumonitis. So radiology suspicion sometimes does not correlate with cytology, but so even that atypia has to be taken with a grain of salt. Now I'm going to show you a case that I got immediately after this. And this was, I say good things happen twice because these are learning cases. So this was another 58-year-old former smoker. So this patient had a really strong smoking history with right lung consolidation. They didn't say there was a mass. And that was concerning for carcinoma. This is what I got. And this is actually, again, a BAL specimen. This was not an FNA. And so you naturally have to process what you can process. And this was all on a thin prep slide. No other history was given to me. And so this was actually a case on call that I got. So I go in, and as you can see, there's a lot of inflammation. Knowing that that other case had a little bit of inflammation, I was like, I have to take, the fellow had screened it, and the cytotech had screened it as squamous cell carcinoma. What I want to point out that there is a lot of these mature kind of squamous cells in the background, and what you can say that those are squamous cells are very cohesive. They're still forming these tissue fragments, plus they have these round halos around the nuclei, which you can see in inflammatory conditions. Naturally, it's a squamous type proliferation, but it does have this spectrum. And I'm kind of a stickler of a spectrum. If I can create a spectrum between the most normal looking cell and the most abnormal looking cell, meaning there are different variation of it, then I'm always thinking more on a reactive process than jumping right away and calling it malignant. So these cells were still very atypical looking. And then as you can see here, really abnormal nuclei, really. So these are still atypical squamous cells. Can I call it carcinoma? Because of that other case, I was really concerning that this is definitely, I have to be really careful. And this was the cell block. And this was a consolidation, not a mass. So I asked for more and more history. The history was this patient had a widely metastatic prostate cancer, and he has received massive doses of radiation because he has developed this angiotactic pattern in the lung, which was concerning for metastasis. So they did give him Lupron, plus he was being treated with radiation. So this is another version of really reactive change that you can see in the lung. The other kicker in this patient was, because of the radiation, he had developed so much pneumonitis and ARDS type pattern that he was placed on a vent. So I always think of Dr. Gupta, who told me that, late Dr. Gupta, that whenever you get these BALs and these specimens from patients who are on vent or receiving massive doses of oxygen, you can develop the most horrific looking squamous metaplasia that can be mistaken for carcinoma. So always passing back, taking another step back, always is helpful in these conditions. So radiation and nuclear atypia is really well described in the lung. They still have that abundant cytoplasm and that vacuolated cytoplasm that we sometimes learn from GYN cytology, because that radiation atypia in those cervical smears, when we look at it, it's very easy. You could say, oh, wow, this cell has that. It still maintains a lot of cytoplasm, which is very typical and vacuolated. So I think that criteria can be used in these cases because that is really helpful. They do have vacuolated cytoplasm and prominent nucleoli. Now, this is one of my favorite papers that came out by Natasha Rexman. She's at Memorial Sloan Kettering, and she described these cases of radiation pneumonitis and reactive pneumocytes in the lung because of the lung injury. And she said that these pneumocytes, when you see in the lung, have what is called as Napoleon head sign. So you have a little dip in the cells. It is half moon shaped, which is very typical of these cells. So I always look for these cells, and you do see them. So in the whenever you're struggling between atypical pneumocytes versus cancer, and you want to exclude the radiation atypia or some kind of a lung injury related atypia, like in ARDS patients, always look for this on cytology specimens, because you can also even see them. So you can see this hobnailing of the pneumocytes in the alveolar spaces is very important. So what are the pitfalls and the pearls, whatever you can see, learning thing is that suspicious radiology always equals cancer in all cases. I mean, one has to really think about acute lung injury. I will tell you two sides, lung and GI. When they have the reactive changes, they can be the most horrific looking changes. I've seen them from esophagus, even in pancreatic FNA, something that was dragged in from duodenum. So you really have to be careful in these cases. So be aware of pleomorphic cells when they are very cohesive and they still have maintained a lot of cytoplasm, because it's possible that those are reactive cells. And when you're thinking of these abnormal cells and what I showed you in her case, you have to kind of also think about sarcomatoid carcinoma, but when you evaluate, this is definitely a case of a sarcomatoid carcinoma. You can see these cells are really abnormal and they lack that amount of cytoplasm that we have in those cases. So this is definitely a slam dunk case of it. And you can see how bad these cells look without any inflammation, and then lack of that, a lot of cytoplasm. So this is definitely a cancer. So clinical history and imaging correlation does help, but in some cases it does not. So as much as you can get the clinical, what is the status of this patient and how the specimen is being obtained is very, very important. You also have to think about sampling and the architecture and all the stuff Momin talked about. So I'm not going to go through this, but this is very important. And triaging of these specimens is very good, and this is where the core biopsy, but remember, core biopsy is very targeted. It targets one area, where these washes and brushes have a bigger surface area. So it's possible that you may not have correlation all the time. So this is one of the papers that I published with Dr. Layfield. It is available online, and this has actually a limited groups of atypias that you can see in pulmonary cytology specimens, and they can be squamous versus those really horrible looking pneumocytes. So I'm going to end my talk here. I think I've shown you two robust cases. And I always have learned from these cases. So I think it's the best way is to learn is also when we sometimes miss a diagnosis or make mistakes, and we are humans, we do make mistakes. So, and I think learning should be it, and we should not be like targeted because we miss a case. That means we don't know something. But so I'm going to end there, and if there are any questions, please feel free to ask. You can always email it to me also. But thank you so much. This has been a pleasure. I wish मैं वहाँ पे होता और आप लोगों के साथ really मिलता जुलता, but things happen, so maybe next time. So thank you so much. Thank you.